I'm very, very excited to have this session today with Jan, where we dive into Simq OSA, a tool for diagnosing obstructive sleep apnea. And in this event, Jan will showcase how Simq OSA combines numerical simulation of airflow with anatomical modeling to help clinicians identify the root cause of OSA and severe snoring. And with the short intro out of the way, Jan, the stage is yours.
Thank you, Jousef. Thank you for inviting me, and I'm really happy to present what we achieved over the last years and what's now there and how it goes on. How would you like to do it, Jousef? Should I just start into the software or?
Let's dive into it. Yeah.
Sure. Then you can watch me how I type in passwords. So because I wanted to open it, one very important part is this one, the CE mark we got for this product. This was hell of an effort to really get a software device into the European market and certified using computational modeling and ML in combination. So this is really something the team and everybody of us can be really proud of, that we managed that to really get a medical device into the market. Other than that, the software is pretty. Oh, I'm not sharing, right?
Not yet, Jan.
Okay, that would help. Sorry.
At least we notice it now, not at the end of the session.
Sorry. Okay, now I'm sharing. So Inception, and now the software tool. Then I'll open it again because it's really something I wanted to show. So is this little CE and this identification number here. So that's what making the difference. Other than that, it's quite easy. So it's just logging in with your user credentials and just starting the software. So now you can see something hopefully and follow us or me what I'm telling. So first of all, you see the dashboard. The dashboard is always the same in our Simq products. So we have all the dashboard technology in our so-called Simq platform. So the Simq platform is basically giving in all the functionality we need for our very easy to use products, that every physician and everybody can use it very easily. And so these base functions, so one of this base function is basically the serialization, so opening products, saving projects, and also showing this dashboard, so of the recent projects basically, and a simulation queue where you have an overview of your running simulations and what is on the cloud simulating and whatnot. And so to set up in simulation in a analysis is actually quite easy. So what you have to do is just like click on new project, select a folder or pre-selected folder. There's automatically a name given, but you can also edit it. So it's quite deep dive. And just save the base project. What you have to do is opening DICOM, so DICOM stack from MRIs. In this version, in the next version, we also including CBCT and CT data. That's just a different modality of patient data you can have, and just import them. So I'll go for the marketing projects. We're not spilling any data. It's very important. Very good. Because there are no DICOM data in there. It was failing. Basically, that's patients we can make advertisement with and show, because that's why we need marketing material data. That's very sensitive. So patient data always very sensitive, and all of that also have to be in the software, of course. So if somebody else is using that, there are no data spills or something else. That's also why you can choose between using the patient data in the project or not. depending on whether you need it. Here in the software, also a functionality of the platform is just rendering DICOM data, so you can scroll through them and just show those MRI data. What you have to know is those MRI data are just voxel data, so it actually just slices with pixels with a depth, and you actually cannot really interpret them very well or make a simulation model out of it. So it is possible, but it's very grainy and you don't know what you get out of it. So you need some mechanism to make a repeatable and good model for this one unique patient that we're doing, and for that we use, of course, ML. What you else can do here is just like select a study or a series. So that's something like DICOMs are prepared. They sometimes, if you're having an MRI, the radiologist makes more than one study and also different series, and you just have to choose the correct one. So sometimes you have a series which is just to position yourself or position the patient in the MRI, and it's just a few slices, which cannot be used for the analysis, of course, and that's why you have to like pick it or select it. So really easy. What do you then do after you selected it? So here is just one series, one study, but after you selected it, you can just import the patient data, which are all GDPR compliant and cybersecure. So there's different standards on cybersecurity for medical devices and other things we have to fulfill. And then you import it and you can use it. That's like the import step. Really easy. Without all that talking, it's really fast. What you then have to do is set 4 landmarks. Sorry. So these are landmarks to identify different anatomies. So basically, what we're searching here is the hard palate. So that's here. In MRI, bones are black, so or dark, because they have less water in it. Then you have to select the tip of the uvula, which is basically the soft palate, and the tip of the epiglottis. This is this little structure here, and vertebra. So usually the 5th or 4th, depending on what is on the on the DICOM. These landmarks are actually necessary to identify these anatomies. So because they behave differently. So the soft palate, for example, or the uvula is like a very floppy and very soft tissue, and the hard palate, of course, cannot move, so it's bone, and the soft palate is attached to this bone. Underneath the sorry, the soft palate, you find the tongue, and also the epiglottis is a very soft but or very special feature we have to identify, because we're mapping or identifying different anatomy regions dependent on this. We have different risk factors on why a patient could suffer on obstructive sleep apnea, or yes or no, and that's what we want to find out with the software. So the anatomical reasons, and for that we have to give some information for the simulation. After that, you just click next, and you have to define a breathing cycle. So either you have to choose those, like the sex, the age ratio, the height and the weight, to calculate the BMI, to generate the breathing cycle. So this is, if you have it in the DICOM data, it's just pulled and you use those data. But sometimes they are wrong and or not given. So then you have to select it yourself. So you can select basically the sex, so not the gender. and the age of the patient, so children's below 14, young adults, adults, and elderly, and type in height and weight. And then you can really easily generate this breathing cycle, which is the boundary condition for the computational fluid dynamic simulation. These breathing cycles are actually calculated based on percentiles of patients and cohorts, how they usually breathe. So the volume, the flow rate, and also how fast they are breathing. So that's different for different age groups, different sex, and also dependent on the BMI that changes. And there's quite good literature out there how to calculate those. And we took those like usual clinical approaches and we're putting it into the software. What you also can do is if you don't use it, you could import the breathing cycle. There are also measurement, so like machines who can measure this breathing cycle, but not every clinic has this. So that's why we're giving this standardized breathing cycle dependent on the patient data. After that, we're done. Simulation is set up, so that's really easy. Pretty much everybody can do it very fast and easy to use. So after we did that, we can just click on send simulation. And if it's configured, you can send it. And the simulation is sent to our cloud. And once saved, and so data are uploaded, encrypted, and sent to the backend. So what we're using is actually so now the solver is executing the simulation. What we're using is actually an Azure backend. So it's HPC computers solving our highly complex simulations and doing also the segmentation, which I'll show you in a second how it works, so what it is to build the models. And these environments usually have something 32 to 64 CPUs and a lot of RAM to really do the number crushing in a reasonable amount of time. So usually an analysis takes about 25 to 30 minutes. I'll show you some prepared projects because we already did it. Here on the recent projects, you can see the status of the simulation. So if it's ready to send, then it's green. If it's done, and then it turns green on this side, and then you can download the results. And if you are downloaded and saved, it is blue. So let's go for this one. I think it's a different patient. Yes, it's a different patient. What you can see, first of all, is the part of the computational model that has been analyzed. So in 3D now, and with one DICOM slice in the middle to have a better orientation. So this is very important for the physicians if they use it, that they can really see where they are in the geometry. If you're just seeing this weird shaped pharynx here, so the airway basically, then it's very hard to tell what is going on in the patient. And this computational model, you could say, so this segmentation, so making actually the DICOM pictures in 3D model, which can be simulated, that's the segmentation what we do with machine learning. That's pretty basic actually. So ML technology with picture recognition, and you train a model, a UNet, to make always the same quality 3D models out of it, and that you can really do analysis on it. And the important part is same quality, that you always have the same quality to really make analytic or medical or clinical decisions based on it. So shouldn't be too sensitive. And after that segmentation, so if the segmentation is done, basically that's the first part of the what's happening on the cloud. then you do a computational fluid dynamics simulation. What you, for example, you can show it. So that's what's usually known for CFD simulations is these streamlines. So what you can see here is the streamlines. So when the patient is breathing in and breathing out. So that's the breathing cycle, breathing in and breathing out. You see all these funny streamlines and the velocity, so how fast the air is flowing in the pharynx and in which region. For example, here you can see where it gets red or green. You have higher velocities because it's getting narrow, and that's like the typical flow field where you also have negative pressures, or negative pressures are developing, or higher pressures depending on if you breathe in or breathe out. They are developing in these narrow regions usually, because of the Venturi effect. So that's the term, I guess. And you can animate this, and this simulation, so this flowing air is giving you pressure. So how high the pressure in a certain region is by breathing in or breathing out. So you can see the pressure changing. It's also something helpful for the physicians. And you can see also a map. So if you don't want to take a look on the 3D images, you can show it as these are always like in the cut section. So it's called sagittal plane. So like in one's rectangular or parallel to, it's hard to say. So like once in that direction. I hope you see my face. And then you see the results dependent on the position and the time. So that's a bit complex to see, but during the breathing cycle. So what you basically see is for here now it's pressure. So the pressure is going downwards. So red is negative pressure when breathing in, and when breathing out, you have a positive pressure here, and then it turns positive again on this side when breathing out. So then you see what's happening in the pharynx. You can also see that in animated, but sometimes you want to take a look on it on certain points at the breathing cycle. So and all this information, so these are actually nice to have informations, but all those informations are used and packed into our so-called Pharyngeal Resistance Index. Typically, OSA patients, or if a patient has OSA, is measured with a so-called polysomnography. So that's like a measurement which you do at night if a patient is sleeping. You can easily, so you have like a wristband, not a wristband, sorry, a band on your chest, and also the oxygen level in your blood is measured on your finger, and also the heart rate and so on. And you can do it at home or in a sleep laboratory. And what they basically measure is the amounts of collapses during sleep. So if you're sleeping and your airway is collapsing and you're not able to breathe anymore, then it's like it's counted, and this is actually then summarized in a so-called AHI index. So this index basically tells how many times you don't breathe during 1 hour. And so severe OSA patients, so really hard OSA or OSA syndrome patients, have that really 30 to 50 or 60 times per hour. So really every minute stop breathing is like diving and don't having any airflow into your lungs, and so into your blood. And which causes a lot of side effects and problems. Actually, that's why OSA is that bad of a disease, because you're getting a lack of blood in your a lack of oxygen in your brain actually during night, and that's very stressful and for your organism, for your brain, and so on. So you really get a lot of problems, and also so sleep disorders, of course, and also um, higher risk of heart attacks and strokes, and a lot of depression, fatigue syndromes, or something like this. So there's a lot of things that come with OSAS, and a lot of patients suffer from it. And what we did actually is we calibrated and validated our Pharyngeal Resistance Index with this AHI index. So how many times you stop breathing during night, but only the anatomical causes. Because that's the problematic thing of obstructive sleep apnea is it is very easy to identify if a patient or if you're suffering from OSAS. So you do this polysomnography and you just count how many times you stop breathing during the night or during 1 hour. Actually, 2 or 3 times per hour is totally fine. So that then you usually don't do that much. But like starting at 10 or 15, I think 5 or 10 times stopping breathing at night, then you have to do something. So you have to get in a therapy. And the problem with that is actually that there are different causes of why you stop breathing at night. So it's one time the anatomical cause that what we are trying to give an analysis for is that some parts of the anatomy are collapsing. So the tongue closes your pharynx, the soft palate, and or a lower part of the tongue, or something else. So other regions are stopping you from breathing, or there's just like neurological effects that you stop breathing. So your lung and your the other anatomies are not working properly, and that's very hard to find out. So um, with the polysomnography, you can really easily identify um, if somebody suffers from OSA, but you cannot identify what's the anatomical cause or what's the neurological cause. And what we did is we calibrated and validated with a lot of 150 patients um, the that we're really telling the anatomical causes and also a risk factor for that. And then the cool thing is also that this risk factor is not only a CFD and geometry, it's actually a statistical value and a value dependent on the surrounding tissues. So if it's like the soft palate or the tongue, what could collapse? Because these have different movabilities and chances and risk of collapsing. So the tongue, for example, is more movable than and the soft palate than the back part um, of your pharynx, because it is the soft tissue is attached to the spine and it cannot move that much. So but the parts, so the tongue and so on, which you can see here, and the soft palate can move and collapse quite easily. And what we can give here is a really nice overview for the physicians. What's what's the anatomical cause and where is it, and what can be done about it in the therapy? So that's the interesting thing here.
I have one question, Jan, for you.
Sure.
If we look at the legend, we show the PRI index. What does the red area mean in this case? How can we interpret it? And what's the practical next step for a physician?
Very good question. So the red part is actually it shows you so 10 is severe and high risk of in OSAS or in collapse in that region. So you see here the pharynx is separated in the velopharynx or in different parts of the pharynx, and here you see basically that this region, so the soft palate here and parts of the tongue, can probably collapse very easily. So the physicians have to decide how to treat that patient. Usually, They use so-called CPAP masks, so which is very so this is the common way, but most of the patient don't accept it because it's like you have an vacuumer direct next to your bed, but it's just turned around so it's not sucking in, it's blowing air into your throat and into your pharynx and the nose, just to keep it open. It is as unpleasant as it sounds, actually. So it's really like it's loud and it's helping, but it's very loud and very not nice to sleep. So you have a hose, you have to, which also looks like something like from a vacuumer, and you have to clean that hose every night, and the masks and so on. And it's like just a lot of work and very cumbersome, but it helps against the OSA. So, but most of the patients don't accept it. So it's like over 60% don't use it longer than half a year or a year. And then there's alternative methods for it. And the alternative methods are there are different things to do. So there are so-called tongue retractors, so which like pull your tongue forward, but this one only helps if your tongue is really the issue. Then there are also like smaller surgeries you can do at the ENT doctor where they remove soft tissue in certain areas or fix it. So for example, what they usually do is like cut the soft palate, make it shorter. But that doesn't mean that it helps actually. So you also don't want to do a small surgery when it doesn't help. So you want to know what it is, what's the best way or how to yeah how to do a targeted treatment. And with the physicians, what they can do now is really to see, okay, this seems to be the anatomical cause. I can do this and that treatment for it, and choose a proper treatment before going into a trial and error and try different treatments till the patient is happy, until the patient is not suffering that much anymore. So that's actually what the software is doing and what we want to do.
Really
Did
cool.
it answer your question, or is it more confusing
No,
now?
no, no, definitely. I'm also wondering, maybe you can explain. Simulation is a good thing to do, but some people see it more like as a commodity rather than a helpful tool. So, how would physicians actually use Simq OSA or like your other Simq tools to make practical or derive practical next steps in their day-to-day work? How does that work? I think that would be interesting to know.
Yeah, sure. So in a day-to-day work, it's really like using it to see the causes of it. One cool application is actually that surgeons who are doing so-called orthognathic surgeries. So orthognathic surgery is basically when you move the maxilla. So here, this bone where your teeth are connected and the mandible, so your lower jaw, when you move them to a different position. And this is really a trend now to do that also for OSA patients, because a lot of patients who are having not a correct bite or something, who have to undergo orthognathic surgery, also suffer from OSAs. And what what we can do is really to show, is the anatomical cause in that region that such a surgery would help, because you don't want to have your mandible and your lower jaw and your upper jaw actually cut. So they cut it off of your skull and then remove it and move it to a new position. You don't want to underwent that surgery if it doesn't help you. And that's the clinical value you can bring here. You can really show if there's an anatomic cause and if it would help. And if not, then probably waive the surgery and do something else. So that's the cause how you can use it, and very easily. Because another important thing is that what we are doing is we are using really patient specific data. We're using machine learning to set up the models and also to interpret the models, but we're using, so every patient is getting its digital twin, and we're deriving decisions and on based on those analyses, and not like having an ML algorithm. Don't saying that machine learning and AI and so is not good, but basically what an AI is doing is having a trained database, so like 500 patients, 1,000 patients more. It's not more than that. So also, so that's the deep learning or machine learning in medicine. Usually it's not more than this amount. And what it's then doing is like guessing to the next patient. So it knows, okay, in these 500 patients, it was this reason. So probably it's that reason in the next patient. And that's actually not patient specific. It's guessing what the next patient could have based on what he already learned. And with our approach, you really do in patient specific digital twin and see what's happening within this patient.
Got it. That makes a lot of sense. Excellent. Let's see if we have a couple of questions. Did you have any other demos, Jan, or is that it?
Not much more. So we can save a
Okay.
report. So you click on this button, and then you can save it as a PDF to have it in your or in clinician's documentation. So I'll just skim through it. Just a summary, what's happening, the different PRIs in the different areas of the pharynx, which I said, so velopharynx, oropharynx, and hypopharynx, and the PRI, and also like the results of PRI pressure and velocity and so on in a just simplified document to see what some rationalities, and that's it. So not much,
Pretty nice. Pretty
but
nice, though. Yeah.
necessary.
Yeah. Probably one of the last, we answered pretty much everything I wanted to ask or we got in the chat. Probably last question for you, Jan. How does integrating in silico simulation with CFD plus what we mentioned, AI and ML in Simq OSA create more individualized diagnosis for OSA patients?
Definitely that you interpret one result. So that's the personalization here, so that you really check what is happening with one patient and interpret those results.
Excellent. I think we can pretty much wrap it up, Jan. How can people inform themselves about Simq and Simq OSA specifically?
Go on the website, send us a message, and if you're at a physician and you would like to try it, just ask the physician and show what we got, and we'll try to give you access to it.
Excellent. Okay. I've already shared the link in the chat. So simq.de/em for the English version of the website. Then you can learn more about Simq and personalized patient care with digital twins. With that, Jan, thank you so much for the session. I'm looking forward to more sessions in the future and have a nice day.
Also looking forward. Thank you very much. Bye bye.